Hello, my name is Dr Hayashi. I'm glad to be here to share my experience of Dmacc with you. This is my financial disclosure. These are the topics I'll talk about today. Why do you perform Dmacc? It is for the two main advantages in Dmacc: excellent visual outcome and extremely low graft rejection. I have started Dmacc in Japan in 2014. Before bringing this technology back home, I visited Germany, where I had a chance to learn from Dmacc performed by Professor Kurz, Dr. Bachmann, and Dr. Tudas. Soon after coming back to Japan, I tried to start Dmacc. However, there were some problems to overcome. The situation in Japan was quite different from situations in Europe or the US. There is a big difference between Japan versus Europe and the US when focusing on causes of bullous keratopathy. That is a study by Professor Shimazaki in 2007. The graph shows the causes of bullous keratopathy in Japan. Most of them are pseudophakic bullous keratopathy, which is the endothelial dysfunction after complex cataract surgery or shallow anterior chamber, which involved laser treatment, as you may know. Despite our careful selection of Dmacc, what I had to face was a complex eye with shallow anterior chamber, high vitreous pressure, a cloudy cornea, and probably a high level of cytokine. I had bad experiences during my learning curve, such as an upside-down fixation or graft rejection. After 150 surgeries in Japan, I got opportunity to study in Germany again. Professor Kuzife and Bachmann kindly welcomed me. I was extremely inspired by their excellent techniques. Observing from excellent surgeries were really important for me to improve my technique. Since most of our cases had shallow anterior chambers, it's very important to inject Dmacc grafts without friction, nor graft rejection. Slow injection should be better, but after implantation, it's not so difficult to unfold Dmacc graft. This is a young phakic patient after glaucoma filtration surgery with shallow anterior chamber without cataract. I'm trying to place 25 gauge needle choker to perform core vitrectomy to reduce the anterior chamber pressure. Now I'm placing Dmacc graft in the IOL injector, then I am injecting Dmacc graft by the help of OVD behind the graft to prevent Dmacc graft ejection. The most important point is to adjust the anterior chamber pressure by tapping paracentesis. Unfolding was very easy due to the shallow anterior chamber that I'm tapping Dmacc graft now. Finally, injecting gas. Finished. As you may already know, it's very difficult to unfold the Dmacc graft in a deep anterior chamber after vitrectomy. In vitrectomized eyes, two bubbles over and under the graft are very effective at unfolding the Dmacc graft in a deep anterior chamber. I developed a special technique with Dr. Kobayashi called the double bubble technique, but he has recently shifted to his holding technique. Now, I can share my double bubble technique. This patient is endothelial dysfunction after vitrectomy and scleral IOL fixation. You can see the Dmacc graft in deep AC, and it was difficult to open it, so I'm trying to inject small air bubble in the roll. This is the first small air bubble. Using it, the Dmacc graft can be opened, but it's not necessary to open it completely. The most important point is not to remove the small air bubble. Now I'm injecting the gas and other graft. I'm repairing the peripheral rim. Finished. This is a very simple technique without any expensive device, and everybody can do it. Now I will share another technique of my colleague, Dr. Kobayashi, a holding technique. In this technique, we hold the edge of the graft, and the graft is easily opened by a tapping technique. Finally, the air is injected under DM and fills the anterior chamber. Using end-elimination light is very effective in checking the correct graft orientation as well as unfolding the graft. This is a very simple technique and it's reproducible. Lowering pressure is important in graft implantation. Double bubble technique and the holding technique are effective in eyes with deep ACs. Careful manipulation should be the key to a successful Dmacc. Dankeschön, ich liebe Deutschland.
Yeah, thank you very much for these impressive videos. Are there any questions? I don't see any questions in the poll or in the Q&A box. What would you recommend us how to deal with Dmacc in Asian eyes? What are the main things except for pressure, vitreous pressure?
You mean the? Could you repeat that?
My question is what to take care of in patients with Asian eyes compared to other eyes, for instance. So, do you take a smaller graft, by for instance, apart from reducing the vitreous pressure, because they have a shallow AC?
In some cases, I'm using smaller graft. And I also use co-vitrectomy to reduce the anterior chamber pressure. Also, I use OVD behind the graft. I'm not using the anterior chamber maintenance, AC maintenance during my implantation because there is a risk of graft rejection in the shallow anterior chamber. It's better to use the OVD behind the graft. It's a very simple technique without risk of rebubbling, I think.
Thank you.
Yes.
Any other questions?
Okay, then thank you very much again. And then we move to Indianapolis. Good morning. We are welcome Professor Frank Price, who got up very early today, I guess, to give a presentation on Dmacc in glaucoma eyes, how to deal with tubes, stents, etc. So please start the presentation of Professor Price.